All right, so now we're going to talk about the application of electrical stim for pain management, how we're actually going to do it. So the learning objectives for this section is really only one, but it's sort of a big one. And it's to be able to demonstrate the elements of applying this. So how do you apply the electrodes? How do you select which device and which settings you're going to use? Custom settings versus preset protocols. Schedule of treatment, duration of treatment, frequency of treatment, and over what time period you're going to extend them. So part of this is a lab, part of what we're going to apply in the lab. But also you should be able to, given a case study on the exam, for example, you should be able to say what you're going to select for these particular things. So adequate dosing. What is adequate dosing? So there's research that is fairly recent that talks about adequate dosing. So honestly, until recently, I always used to say to people that, it should feel strong but still comfortable. And actually, the amplitude should be almost not comfortable. It should be tolerable but really strong. And if you're doing a sensory application, it needs to be just sub-motor. Like if you turn it up one more setting, you would get motor twitching. So just sub-motor. If you're trying to do low-frequency TENS for a motor application, for that stimulation-produced analgesia using the endogenous opiate system, it needs to be at the motor threshold. In other words, you want to get twitching. So pretty high amplitude. Not as high as lightning, but pretty high. Higher than I've used in the past, honestly. Frequency, of course, for low rate, it's going to be 1 to 8 pulses per second, or 1 to 10, or cycles per second. And at the high rate, it's going to be 25 to 150 pulses per second. So get out your strength duration curve. Actually, you should have that out all the time when you're listening to these lectures and when you're studying for electrical stim. The strength duration curve is your guide for doing these things. So if you look, 150 pulses per second on the strength duration curve, we are submotor. We're not trying to stimulate those motor nerves. We're trying to keep it to the sensory nerves. So the duration of treatment should be 20 to 30, a minimum of 20 to 30 minutes per session. So in terms of planning a therapy session, we know that electrical stim is not well reimbursed by insurance companies, and unfortunately reimbursement drives therapy decisions. As much as the idealists among us want that not to be true, it is true. And so you might not choose this as an intervention just because of that. But you might be training someone how to use their TENS unit at home, and we want to tell them this is what we want, 20 to 30 minutes per session. You want there to be the opportunity for multiple treatments over time because there is research that indicates that that multiple treatments over time demonstrate a cumulative positive effect. Interesting, right? So we want to treat a sufficient area, still on the idea of adequate dosing. So the paresthesia, or the decreased sensation, should cover the painful region. That's sort of a duh statement. It seems like common sense, right? You want that to cover the painful area, but just think about where the painful region is, how deep it is. If the electrodes are closer together, you're going to get a more superficial flow of current. If they're farther apart, you're going to get a deeper flow of current. Also taking into consideration what tissues are deep to the surface that you're working on. You want to have a sufficient number of electrodes and channels to cover that painful region. So if you have one channel, it's 2 electrodes. If you want to do a quadrupolar setup, you need to have 2 channels for 4 electrodes. You want to have a sufficient size of electrodes, so larger area, bigger electrodes, smaller area, smaller electrodes. A lot of this seems like common sense, but we have to lay it all out there. The electrode placement should bracket the painful region. So you want to surround that area that's painful. The implications are that there is evidence to substantiate the use of TENS and other electrical stim applications in selective pathologies. So the studies that are out there now might lead you to other studies that provide further evidence of the efficacy of this treatment with certain diagnostic categories. When systematic reviews are analyzed with the consideration of dosing, electrode placement, potential drug interactions, sufficient number of treatments, type and timing of outcome measures, and overall, evidence supports the use of TENS across several diagnostic categories. So case reports may document the effectiveness of TENS in managing specific types of pain. So remember, a case report is one or a few people, and you can say, yes, it was effective for these people with this condition. But those case reports might lead us to randomized controlled trials that evaluate the efficacy of the intervention over diagnostic categories for larger groups of people. So those randomized controlled trials are what we really want to see, and systematic reviews and meta-analyses take it into a larger scale. So we can use battery-operated TENS units, or interferential current is frequently used in the clinic for the same type of thing. Not that you can't use TENS units in the clinic, because you can. And we're going to experiment with a lot of these in the lab. So the TENS waveform, it's pulsatile current. IFC is alternating current. So normally for pain management, we're going to use either pulse current or alternating current. And so battery operated is the TENS and the line current is IFC. Pulse duration is going to be from 50 to 300 microseconds. Submotor threshold, remember? The frequency is going to be 1 to 50 pulses per second. 1 to 10 for the low rate, and probably 50 to 150 for the higher rate. The amplitude for each channel is usually going to be 1 to 80 milliamps. So that, again, is going with the patient's sensation, how they feel. Giving the patient control of the amplitude gives them a feeling of confidence and feeling like they can control what's going on, which helps, really helps. Lead wire jacks usually are going to have 2 channels, 4 electrodes, quadrupolar setup. Not always, but usually. Modulation selection, so we can modulate rate, amplitude, duration, or a combination of those. Burst mode is where you're delivering those packets of higher current density to get the effect that you want. Pre-program modes, like you'll see on this machine, and we have these in the lab that we'll look at. They have knee, back, shoulder, etc. Those are preset modes because this is targeted to an end user. That's not saying that you have to use the knee mode on your knee. You can experiment with different modes and see what works the best for you. Waveform options, it's basically going to be pulsed current, monophasic or biphasic pulse current. Of course, biphasic pulse current is largely the most commonly used. It can be symmetric or asymmetric, and you want it to be balanced, so 0 net charge. We don't have net charge building up under the electrodes. The alternating current application is going to be interferential current. Carrier wave frequencies around 4,000 hertz with the 2 interfering channels. 1 to 150 beats per second, usually 80 to 150, and we usually modulate it with IFC. So the waveforms we talked about, direct current, pulse current, alternating current. For pain management, we're going to be using either pulsed or alternating current. The electrodes we've talked about, lots of different choices. Normally for the home use units, they are the self-adhesive, reusable electrodes. You're going to choose the electrode which fits your application. Usually a bipolar or quadrupolar setup surrounding the area of pain. If you're using IFC, you have to cross the channels. That's how you get the interference. So conventional or sensory level, comfortable sensory input below the motor threshold. consider a strong, tolerable sensory input. So you can even say barely tolerable. We want to increase the amplitude every 3 to 5 minutes to permit the patient to habituate to the stimulus and tolerate a stronger one. If we educate them that the stronger amplitude they can tolerate, the more they're going to get out of it, that's going to be to their benefit. And most people, it's going to be around 15 milliamps, but that's going to vary from person to person. Pulsatile current, it's going to be monophasic or normally pulse biphasic. Alternating current, we're doing IFC, and it's usually at greater than 50 pulses per second. Pulse duration, remember we're going sensory level, 50 to 200 microseconds or 50 to 300, you'll see in other sources, but below the motor threshold. Treatment duration is variable, but minimum between 20 and 30 minutes. Often, conventional or sensory level is the first mode attempted. It might be the mode of choice if the patient is using codeine-based or opioid-based medications and has become tolerant to the method of application associated with such medications. So we can't use the opioid receptors because they're being used by the medication, and so we need to access the pain control mechanism through an alternative system. In other words, the gating system at the spinal cord. Low rate or motor level uses the stimulation-produced analgesia, stimulating the midbrain to release those endogenous opiates. It uses those opioid receptors, so this is probably not the mode of choice for someone who's on opioid medications. We're at the motor twitch level, biphasic pulse current or alternating current at a lower frequency. Higher amplitude at the motor threshold, we want twitching. Pulse duration 200 to 400 microseconds. So we want to get into that motor neuron level. So take a look at your strength duration curve, motor neurons. A little bit longer treatment duration potentially, 20 to 45 minutes. Associated with that stimulation-produced analgesia, where we're stimulating the midbrain to produce those endogenous opiates. So the pain relief outlasts the treatment session. Normally with conventional high rate, the pain relief only happens during the treatment session. With this, the pain relief outlasts the treatment session. It's opiate mediated, thus patients also taking opioid medications may develop tolerance to this mode of stimulation. They might already have a tolerance to it because they've already used up their opiate receptors with those medications. So burst mode or high volt, not as commonly used, but it's usually indicated for maximum pain relief during an uncomfortable procedure. Maybe you are doing some joint mobilization or overpressure on someone to get their range of motion after surgery. It's mono or biphasic pulsed, higher frequencies, higher pulse duration. It's high amplitude, uncomfortable. We're looking for motor fasciculations. So we're actually stimulating those motor nerves. It's a short duration treatment to mask pain, maybe during something like debridement, and it's opiate mediated. So the noxious level, which is hyperstimulation, I've Captain Noxious superhero there. It's a point probe stimulation for longer lasting pain relief. I've only done this one time. When I was a student, I did a clinical assignment in a clinic where they used this, and it worked, and the patient could tolerate it. But it's not well tolerated by many patients. It can be direct current or monophasic or biphasic pulse current. It's a point electrode, so it has a high current density. Remember, current density is related to the size of the electrode, so smaller electrode, higher current density. Variable frequency, depending on what effect you're trying to get. The pulse duration is going to be long pulse duration, way up into that C fiber range on the strength duration curve. The amplitude is set at the maximum tolerated level, 30 to 60 seconds per point. So it's a trigger point, a motor point, or an acupuncture point. And a lot of patients cannot tolerate this. you're stimulating that opiate response. So this is something you're not going to see that often, but it's just something to know about. So these are your parameters. You'll have this in your references to go through, comparing conventional high rate TENS to low rate TENS. We've already gone through these parameters. This is comparing the duration, the safety, the typical conditions that you're going to use it for, and the duration of application. A lot of times, for where I've had success in the clinic with low rate TENS is when people come in with headaches. They've already been screened to know that it's not a brain tumor or something that they need to be referred out for, but they just have an intractable headache or an intolerable headache that day, and I've had good results with low rate TENS. The other time is when you have someone with seemingly intractable pain, where they're twitching, they're crying, they can barely even talk to you, and they're just begging you to take away the pain. I've had good results with low rate TENS in that, because you're not going to get any exercise out of them that day when they're like that. They are not going to tolerate manual therapy, and sometimes low rate TENS is a last ditch effort. Like, I got to do something for this person. I'm going to do this. Interferential current. Medium frequency devices, 2 channels that interfere with each other. There's a theoretical decrease in skin electrode impedance with a higher carrier frequency. We're not adjusting the carrier frequency a lot, but that's one of the ideas as to why IFC is desirable. It's been stated that there's a deeper or more focused stimulus, but that's not proven. It's questionable. The ability to target or sweep electrical fields may not be clinically significant. So even though that's stated as a reason to use IFC, the jury's out on whether or not that's true. It's that sinusoidal alternating current waveform, so we're talking about hertz or cycles per second rather than pulses per second. The beat frequency is determined from 2 separate heterodyning or conflicting frequencies, interfering frequencies. It's the difference between the 2 frequencies. So that's why you don't set your beat frequency or pulse duration in alternating current. It's inherent to the machine. True IFC requires interferential electrode placement, meaning 2 channels crossing with the vectors intersecting. Pre-modulated IFC, which its nickname is pre-mod, is sort of just like traditional TENS application with a burst or beat mode. So the time that you want to use IFC, or pre-mod, is when you don't have room for 4 electrodes. So you're on somebody's hand. There's just not a place to put 4 electrodes on somebody's hand, and so you're using pre-mod because you want that effect, but you don't have room for 4 electrodes. So IFC, you can modulate the frequency, which is called vector sweep or just sweep. It modulates between 2 sets of frequencies or between 2 sets of ranges of frequencies, a low range and a high range, and that's all set up on the machine, and we'll try that in the lab and see if you find that useful. Vector scan, or to be simple, scan, is amplitude modulation. So scan modulates between the high amplitude that you and the patient agree on and some percentage below that set amplitude. So it always modulates down. It's never going to go higher than the highest amplitude you've set. So if you decide that you and the patient decide that this is the amplitude that they can tolerate, and you put it on a 40% scan, it's going to go from that high set amplitude to 40% below that, and then back up to the high that you've set. If you have a 100% scan, it's going to go from the highest amplitude that you've set down to nothing and back up to that amplitude. So it always modulates down. Modulated modes are supposed to help combat habituation to a comfortable stimulus. So you can have combinations of those, but if the amplitude is sufficient, do you really need other modulatory choices? So if you keep turning up, if you coach your patient and keep turning up the amplitude so they don't habituate it to it, do you need modulation? So that's something that we can try in the lab. And interestingly enough, whenever usually in the clinic you're finding a comfortable but tolerable setting, or strong but tolerable setting, and then you're leaving it on and maybe ramping up the amplitude a little bit each time. But in the lab we really get to experiment, and some students think the modulation is really helpful, and some students say, you know, I like it better without the modulation. So you can try and figure out what you like the best. So electrode, there is no evidence base to determine preferred sites for specific applications. So it is a little bit of trial and error. Sometimes you're trying a sensory level application and you're getting motor twitching, and the thing you need to do is turn off the machine, move the electrode a little bit so you're not on a motor point. There is evidence that indicates that electrode surface area has to be sufficient to cover the target region. So there is evidence about that, but there's not specific preferred sites. It should be at or near the site of pain. There's another duh moment right there. Or surrounding or bracketing the site of pain. So the evidence talks more about covering the target region than specific electrode applications. There is a theory of putting it proximal to the site of pain along associated peripheral nerve is going to be effective. Again, not proven in the evidence base. Paraspinal placement at associated nerve roots, it's another potential. Or on associated dermatomes or myotomes. So a lot of times you are trying to figure out what the person you're working with responds best to. There's not a huge research base that indicates that any one of these is better than another. You want to make sure that intact sensation is there because it's essential for safety and effectiveness. So you want to test for intact sensation prior to treatment. You want to adjust the intensity on an area of intact sensation. So you don't want to exceed the level of stimulus that area can tolerate. So if you have an area, like a lot of times after knee surgery, someone will have around their incision, they'll have areas with no or limited sensation and areas with intact sensation. So when you're adjusting your intensity, adjust it on an area of intact sensation and don't exceed that level when you're going to the area with less sensation. Hopefully that makes sense. You want to monitor the person's skin response. Is it turning their skin red? Are you getting an electrode reaction? There is limited evidence that subsensory stimulation is effective for pain control. In other words, if you can't stimulate the sensory nerves, it's not adequate dosing for getting a sensory level response. So don't do it. Really, basically. So we talked about, we'll talk more about this in lab, skin prep. You want to make sure the skin is clean and oils are removed. If they're super hairy, well, you know, super hairy, that's a questionable. If they're too hairy for the electrodes to stick to them, then you need to shave or clip hair or have them do it before they come in. A lot of times when we're doing functional electrical stim, we will coach the patients in the session before their FES session where to shave or clip their hair before the session, or their spouse or caregiver. Sometimes you might need to apply conductive gel or moisten the electrode to get good conductivity. If you use hypoallergenic tape, you want to go parallel to the long axis of the electrode. And you want to remove the tape in the direction of hair growth. We're not trying to do hair removal with the tape.